Hello, everyone. Good day, and I welcome you back to today's talk, which is on anatomy of the gluteal region and the hip joint. As you know, I'm Dr. Rehan Folarin, and today we'll be exploring together the muscles, the neurovascular supply, the boundaries, and clinical relevance of the gluteal region. And we'll also discuss the anatomy of the hip joint while touching on the ligaments and common anatomical variations in this region. But guess what? Before we dive into today's lecture, I'd like to give a big shout out as promised to some amazing students who correctly answered all the multiple choice questions from the last discussion we had on the osteology of the lower limbs. So on that note, I say a big congratulations to Dorcas Oluwatomisin. And yeah, she was the first person to get it right. And also, congratulations to Olumburi, to Olope. Same to Abdulrazak Fatiha. Congratulations. I also congratulate Hosseini Uluwajeda. Congratulations as well to Hassana Barua. Congratulations as well to Mercy Fortune. I congratulate you all. I also want to recognize those of you, who participated and tried your best, even if you didn't get all the answers correct. So on that note, I'm saying a big shout out to Adufumilayo, for being the very first person to drop an answer, to drop a complete answer. So you did an amazing job getting most of the answers right. So just one more to go. So keep up the excellent work, and I'm sure you'll get it all right the next time. So to you all, I say congratulations, and I want you to remember that every effort counts, and it's all part of the learning process. So don't stop engaging because it's key to mastering these anatomical concepts. Your dedication definitely inspires others, and it keeps the interactive learning thriving. So don't forget, there will be more multiple choice questions during today's lecture, so stay tuned and get ready to participate. To be specific, actually, I have 9 MCQs spread throughout the lecture. So at the end of the lecture, I encourage you, like always, that the first 5 students to compile all the correct answers. I'll be expecting to see who those are, and to drop them in the comment section. So let's see who gets all the answers right first. So, by the end of today's lecture, you should be able to describe the boundaries and layers of the gluteal region. You should be able to identify and discuss the origins, the insertion, the nerve supply, and the actions of the different gluteal muscles. We also expect that you understand the neurovascular supply of the gluteal region, and then to explain the anatomy of the hip joint, including its ligaments and clinical correlations, and it's expected that you would be able to appreciate a number of clinical conditions and variations that are related to both the gluteal region and the hip joint. So let's dive in. So by way of overview, the gluteal region is that posterior region, the posterior aspect of the hip, which plays an important role in locomotion and stability of the lower limbs and the entire body. So let's define its boundaries. Superiorly, the gluteal region is bordered or bounded by the iliac crest, the crest of the iliac bone, and that's also indicated here. While inferiorly, there is this fold you have between the gluteal region and the thigh, the back of the thigh. So that's referred to as a gluteal fold or the inferior gluteal cleft. Okay, so this is the inferior boundary. While laterally, the gluteal region is bordered by the greater trochanter of the femur, while medially, the gluteal region is bordered by this cleft, the intergluteal cleft. That's the cleft you have between both both gluteal regions. So with this, we understand the boundary, the extent of the gluteal region. Now, in terms of layers, the gluteal region is organized from superficial to deep as follows. You see the skin, first of all, which is where you have a rich supply of cutaneous nerves, and then you have the superficial fascia, which contains the fat, a lot of fat depending on the gender, and it has a number of blood vessels and cutaneous nerves. Deep to this is the deep fascia, okay, which is the fascia lata that encloses muscles which thicken generally, laterally. The fascia lata, the deep fascia thickens laterally to form the iliotibial tract, the iliotibial band, which runs from the ilium down to the tibial bone. So on it inserts or into it tapers the fascia lata or the deep fascia. Next to this or deep to this, you have the gluteal muscles, which are subdivided into superficial and deep group of muscles, which we'll come to shortly. And then you then have the bones and the neurovascular structures. So you have the bones, the, the posterior part of the ilium, the posterior surface of the ilium, then you have the sacral bone, the coccyx, and you have the femur contributing to that area. So the muscles of the gluteal region are divided into two groups, like previously mentioned. So the superficial group of muscles consists of the gluteus maximus, the gluteus medius, and the gluteus minimus, which is deep to this. And you also have the tensor fasciae lata, usually considered along with the three gluteal muscles as being superficial, even though it's more anteriorly placed, as we'll come to explore shortly. So we also have some the other group of muscles being deeper, and this is where you have the piriformis, the obturator internus, the superior and inferior gemelli, and the quadratus femoris. All of these muscles function to enable movement of the hip, especially extension of the hip, the abduction of the hip, the rotation of the hip, and then they all contribute towards the the stabilization of the hip joint. So you would appreciate those muscles here, and some other muscles that are shown here will be explored during our discussion about the thigh. Which suffices to appreciate the gluteal region by mentioning the gluteus muscles along with the tensor fasciae lata. So going more into the superficial muscles of the gluteal region, as mentioned, the gluteus maximus is readily seen exteriorly here. And then you have the gluteus medius, and then we'll be exploring the gluteus minimus as well as the tensor fasciae lata. The gluteus maximus arises from the posterior gluteal line, which you have on the ilium, right? And it also arises from this region of the sacrum and then the coccyx, okay, as well as the sacrotuberous ligament. So from this, the muscle goes in this direction to insert, as you can see here, on the ILT or ILB, iliotibial tract or iliotibial band, all right? And it also inserts on the gluteal tuberosity of the femur. It inserts on the gluteal tuberosity of the femur. So the muscle is innervated by the inferior gluteal nerve because it's by way of its division, it readily has access to the gluteus maximus. So which is, the inferior gluteal nerve is made up of the L5, S1, and S2 spinal nerves. And by virtue of the point of attachment of this muscle, the point of insertion of this muscle, you can expect it to assist greatly in hip extension. Whenever it contracts in this direction, it's able to extend the hip joint, right, by pulling the femur backward in the backward direction. It also helps with lateral rotation, which is the head of the femur turning backward. Okay, so that's lateral rotation of the thigh, and it also contributes generally to stability whenever an individual is standing. So chiefly, it helps in extension and in lateral rotation. So whenever there is a weakness in this muscle, that results into gluteal lurch. So the gluteus maximus is very essential while climbing stairs because in order to lift up the already flexed thigh. From that flexion position, you need extension to raise up that flexed thigh in order for the contralateral limb to also raise or to also meet up to that level and climb the next stairs. So that extension movement is very important, and that is chiefly coordinated by the gluteus maximus. So an individual that has paralysis or weakness in that muscle will find it difficult rising out of a chair, standing up from a chair, or climbing stairs and maintaining an erect position. So this weakness would also result into difficulty from movements that require extension. So that difficulty arising from a sitting position is what's usually referred to as lurching. And the gluteus maximus is also a site for intramuscular injection, particularly at the upper outer quadrant. All right. Next is the gluteus medius muscle, which originates, as you can appreciate here, from the external surface of the ilium between the anterior and posterior gluteal lines. And it goes all the way down to insert on the lateral surface of the greater trochanter. So by virtue of this point of attachment, whenever this muscle contracts this way, you can expect that it's going to pull, it's going to pull this bone laterally. It's going to pull it in this direction. And that is what? That is abduction, right? So this is a chief function of the gluteus medius muscle. So whenever it contracts, it abducts the thigh. And it also helps with medial rotation of the thigh, which is the head of the femur turning anteriorly, okay, such that the greater trochanter rotates more anteriorly. So it also contributes generally in stabilizing the pelvis, particularly while walking, by preventing what we call pelvic drop on the opposite side, which is otherwise known as the Trendelenburg sign, which we'll come to in a moment. So it's innervated by the superior gluteal nerve, okay, the superior gluteal nerve, while the previous muscle we discussed, which is the gluteus maximus, is innervated by the inferior gluteal nerve. Next, clinically speaking, damage to superior gluteal nerve will therefore cause that Trendelenburg sign, okay, which is when you have the pelvis dropping on the contralateral side during walking. It's not a normal thing. So for a normal person, the person doesn't have a pelvic drop while in the contralateral side while walking. But for a person with a weakness in the superior gluteal nerve, will have such a challenge. So that's called the Trendelenburg sign or Trendelenburg gait, okay, which is a drop of the pelvis when lifting the leg opposite to the weak gluteus muscle, gluteus medius muscle. So there could also be a tear or tendinopathy in the gluteus medius muscle, and whenever that happens, it leads to pain over the greater trochanter on which the tendon of the gluteus medius muscle inserts. So a weakness in this muscle will also lead to a deficit in abduction, in the abduction of the hip or of the thigh, right? So, and that leads to a kind of gait known as waddling gait, okay, as well as the lurching. Also, multiple bellies could exist in the muscle, in the gluteus medius muscle, in some individuals. So they may have a superior accessory belly of the gluteus medius muscle. So lurching can actually be considered as a synonym or a description of the Trendelenburg gait. So, in fact, the lurching gait is often used to describe the abnormal swaying motion that is characteristic of the Trendelenburg gait, which occurs due to weakness or instability in the hip abductors, particularly the gluteus medius and gluteus minimus muscles. So, these terms are used interchangeably because in Trendelenburg gait, when a person stands on one leg, The pelvis on the opposite side drops due to the inability of the weakened hip abductor muscle to stabilize the pelvis. So this causes the person to lean or lurch towards the affected side in order to compensate for the pelvic drop. And this results into an abnormal side-to-side swaying of the body as the individual is walking, so which is what is often referred to as lurching, that side-to-side abnormal swaying of the body. So while lurching is not a formal medical term, it's, it actually describes that swaying, the compensatory movement that is seen in individuals with Trendelenburg gait. So don't be confused when we talk about a waddling gait or it's lurching gait or Trendelenburg gait. So Trendelenburg gait is, or Trendelenburg sign is the actual medical term, but lurching is one common way it shows itself. So like the gluteus medius, the gluteus minimus also plays a role in the abduction of the hip and in the stabilization of the hip joint. So the muscle originates from the external surface of the ilium, as you can see here, between the anterior and inferior gluteal lines, and then it inserts on the anterior surface of the greater trochanter. So when this muscle contracts, it also contributes to hip abduction and also medial rotation of the head of the femur, thus stabilizing the pelvis during locomotion as well. So it's also supplied by the superior gluteal nerve, which is contributed to by the S4, L5, L4, sorry, L5 and S1 spinal nerves. So this is so in cases of femoroacetabular impingement, the gluteus minimus involvement can result in a referred pain and loss of joint motion, loss of the motion of the hip joint. Okay, and yeah, we've mentioned the Trendelenburg gait. So when the muscle is, when there is an impingement or a paralysis of the superior gluteal nerve, it weakens the muscle, thus contributing to the Trendelenburg sign as well. So this muscle works hand in hand with the gluteus medius in order to achieve the abduction and medial rotation movement. So dysfunction here can exacerbate the Trendelenburg gait and contribute to chronic hip pain. Next is the tensor fasciae lata, which is a small muscle that is enclosed within the iliotibial tract, or it starts on it as well. So it's referred to as arising or originating from the anterior iliac crest and the anterior superior iliac spine. And then it goes to insert on the ILT or ILB, the iliotibial band, which attaches to the lateral condyle of the tibia down here. So it's also innervated by a superior gluteal nerve, while based on this point of its attachment, you can expect that its action includes flexion because of its position, flexion of the hip joint. So it assists in the flexion of the hip joint. It also assists in abduction of the hip joint and in the medial rotation of the hip joint. But by virtue of its name, tensor fasciae lata, its major action is the tensing up of the fascia lata, which is the deep fascia that you have surrounding the gluteal muscles and the muscles of the thigh. So it also stabilizes the knee joint by virtue of its tensing action, the pressurizing action that it confers on the fascia lata. So clinically speaking, there could be what is called the iliotibial band syndrome, which is often uh, defined as a pain due to friction in the iliotibial band during frequent use or movement. So there could also be the snapping hip syndrome, in which the ITB, that's the iliotibial band, or the tensor fasciae lata, is snapping over some of the bony prominences. So whenever this happens, it can result into some pain as well. So that's a snapping hip syndrome. So the TFL also plays a key role in stabilizing the pelvis during walking, and its weakness or tightness can affect postural control and contribute to pain in the hip and the lumbar region. So this is some of the it's one of the exercises with which the TFL is trained, or the pain in it is also is tested and worked upon. So the compartment syndrome, in rare cases, you have excessive use of the TFL leading to hypertrophy of the muscle that is growing beyond its normally expected size, and then it will lead to a potential compartment syndrome because there is already a compartment created for the muscle which finds it hard to expand as the muscle uh, expanded beyond that limit. So you would notice that all the gluteal muscles, the superficial gluteal muscles, receive innervation from the superior gluteal nerve, except the gluteus maximus, which receives the innervation from the inferior gluteal nerve. So take note of that. And that's as a result of the location of the muscle. So let's begin with our first MCQ to test your understanding of the boundaries of the gluteal region. Which of the following forms the superior boundary of the gluteal region? Is it the greater trochanter, the iliac crest, the gluteal fold, or the sacrum? You know what to do. Drop your comments or your answer in the comment section and keep compiling them till we get to the end of the lecture. Our second question here it is. So the primary nerve supply to the gluteus maximus is what? I just recapped it now too. So take your time, think about it, and tell whether it is the superior gluteal nerve, the sciatic nerve, the inferior gluteal nerve, or the obturator nerve. We have a third question, which is asking about which muscle contributes to the stabilization of the knee joint via the iliotibial tract. Is it the gluteus medius, minimus, tensor fasciae latae, or the quadratus femoris? Now, let's discuss the deep group of gluteal muscles, which are crucial for lateral rotation and stabilization of the hip joint. Um, and by stabilization of the hip joint, we mean stabilizing the head of the femur within the acetabulum of the hip bone. So these muscles include piriformis, the obturator internus, the gemelli, as the superior and inferior gemelli. Gemella is the plural. Gemellus is the singular. So that the superior gemellus, inferior gemellus, or superior and inferior gemelli, and then the quadratus femoris. The piriformis muscle, to start with, is pear-shaped, and it originates from the anterior surface of the sacrum. So here you are looking at the posterior surface of the sacrum. So the origin of this muscle is in front of this bone, which you can't see the exact point of origin because the posterior part of the bone is currently covering it. So you understand what this means. So it goes from the anterior surface of the sacrum to insert on the greater trochanter. So by virtue of this, you can expect the movement, the action of the muscle to be what? Abduction, first of all, by virtue of this point of attachment. So it's able to help with abduction, and then it contributes to lateral rotation of a thigh that is already extended. When the thigh is extended, the thigh is already posteriorly orientated, then you then want to laterally rotate that thigh. The piriformis comes into action in this instance. So it's innervated by what we refer to as the nerve to the piriformis, and that's contributed to by the first and second sacral spinal nerves. So the piriformis syndrome occurs when the sciatic nerve is compressed by the piriformis muscle. Because of this position, it's closely related to the sciatic nerve. So when the nerve is compressed by the piriformis muscle, it causes irradiating pain. and patients tend to experience this radiating pain down to the posterior thigh. Okay, and that mimics what is known as the sciatica, which is inflammation of the pain in the sciatic nerve. So, an anatomical variation that happens to the piriformis is an individual is that part or all of the sciatic nerve may pass through the piriformis muscle instead of underneath the piriformis muscle, as is typical for normal individuals. For normal individuals, you find conformist, the piriformis muscle passing underneath it. For some individuals, you find it passing through the muscle, thus predisposing them to the piriformis syndrome. The obturator internus muscle forms part of the lateral wall of the pelvis and is closely related to the obturator nerve. Like we mentioned in osteology, everything around this area have the surname obturator, obturator foramen, obturator, this and that. So pathologies affecting the obturator internus will also um, will go around this area. So the muscle originates from the inner surface of the obturator membrane, and that's what we are looking at here. So, and it also arises from the surrounding bone, the bone that surrounds that inner obturator membrane, inner surface of the obturator membrane, and it goes to insert on the greater trochanter of the femur, medial surface of the greater trochanter of the femur, as you can see here. So, if this muscle contracts, you can expect what? Movement of the head of the greater trochanter posteriorwards, leading to what? Lateral rotation, and it also contributes to abduction of the thigh when the hip is flexed. So abduction of the thigh when the hip is flexed, such as when one is sitting and you want to open the legs. So the muscle is innervated by the nerve to the obturator muscle, which is S1, which is contributed to by L5 and S1 spinal nerves. And pathologies affecting the obturator internus, like abscess, can result into pain during the movement of the hip joint. So this is a close relation. Next is the superior and inferior gemelli muscles. So these small muscles, they stabilize the femoral head in the acetabulum, and they originate. So there are two of them. The superior is right here, and then the inferior is right here. So as for the superior, you can see it's originating from the ischial spine. Here is the spine of the ischium. Remember, this is the posterior superior iliac spine, and here is the posterior inferior iliac spine. This on the far away end is the anterior superior iliac spine and the anterior inferior iliac spine. So beneath the posterior inferior iliac spine, you have the ischium, the ischial spine here. So that's where the superior head of that's where the superior gemellus arises from, while the inferior gemellus is arising from here, and this is part of the ischial tuberosity. So they both go to insert on the tendon of the obturator internus. You can see they are closely related to the obturator internus. This is the obturator internus on the right side, and here it is on the left side. So see the close association between the obturator internus, seemingly in the middle, and then the superior and inferior gemelli muscles. So the gemelli are actually named because of their twinning structure. So they derive their name from the word gemellus. The gemellus means little twins because gemellus is actually the diminutive form of Gemini, the same Gemini you know in the app. So you may want to ask Google why the name. So Gemini means twins actually. And the term was used because you can see the two gemelli muscles appeared. They are paired and then they are located on either side of the hip joint as well. So the superior one refers to that muscle above the obturator internus, while the inferior is below the obturator internus. And we understand that they are named, for their mirrored paired arrangement, as they are acting more or less like twins. Okay, so they can also be considered as twins on both sides of the obturator internus. So twin muscles that are working in tandem to help with the lateral rotation of the hip. Okay, so they are innervated by the superior by the nerve to the obturator internus. Okay? The superior is innervated by the nerve to the obturator internus, while the inferior gemellus is innervated by the nerve to the quadratus femoris. So, injury to the superior gemellus or obturator internus can actually lead to localized pain in the gluteal region, particularly during lateral rotation. Okay, next is the quadratus femoris, and this originates, as you can readily see, from the ischial tuberosity, and it inserts on the intertrochanteric crest of the femur posteriorly. So if this kind of muscle contracts, you expect it to confer what? Lateral rotation, and that's why it is considered a strong lateral rotator of the thigh and also a stabilizer of the head of the femur. So it's innervated by the nerve to the quadratus femoris, which is contributed to by the L5 and S1 spinal nerves. So quadratus femoris can actually be involved in ischiofemoral impingement syndrome, okay, where the muscle compresses soft tissues between the ischial tuberosity and the lesser trochanter, thereby causing pain in the deep gluteal region and the posterior hip. So, um, speaking more about the neurovascular supply of the gluteal region, it's something very critical for the understanding of the functional integrity of the muscles and structures in this area. As for nerve supply, we already talked about the superior gluteal nerve and the inferior gluteal nerve. So the superior gluteal nerve supplies, like we mentioned, the gluteus medius, the gluteus minimus, and the tensor fasciae latae, which have been cut here. So from the point of emergence of the superior gluteal muscle, you see it's readily available it's readily accessible to those three muscles mentioned. But for the inferior gluteal nerve, it's readily is readily related to the gluteus maximus, which is cut here. And this is the muscle that gets innervated by the inferior gluteal nerve. Okay, as it comes out here, so it innervates the gluteus maximus muscle. Next, you have the sciatic nerve, which is the biggest nerve you have in the body. It passes through the greater sciatic foramen, just like the piriformis muscle as well. So the sciatic nerve passes through the greater sciatic foramen inferior to the piriformis muscle. And then it provides innervation to the posterior thigh and the entire lower limbs below the knee region. And then we also have the posterior cutaneous nerve of the thigh, which is not shown here, is a cutaneous nerve. So it's contributed to by the first to third sacral spinal nerves, S1 to S3. So it supplies the skin over the posterior thigh and the gluteal fold. So take note of those forming nerves. And you see the gluteal artery and nerve going together. So the superior gluteal nerve and the superior gluteal artery, and then the inferior gluteal nerve and the inferior gluteal artery. So the superior gluteal artery also supplies the gluteus medius and minimus and the tensor fasciae lata, while the inferior gluteal artery also supplies the gluteus maximus and the deep gluteal muscles. As for venous drainage, you have the superior and inferior gluteal veins accompanying their respective arteries to drain into the internal iliac vein, which is further typified here. So the neurovascular structures in this region are prone to injury during intramuscular injection in the gluteal region. So the chiefly implicated nerve, the nerve at most risk during intramuscular injection in the gluteal area is the sciatic nerve. Okay, if improperly done, especially when the superior outer quadrant is not used, then the sciatic nerve is actually at risk everywhere else. So at other parts of the injection of the gluteal region, if whenever the injection is administered. So to prevent sciatic nerve injury, injections should be placed in the upper outer quadrant of the gluteal region. So additionally, anatomical variations of the sciatic nerve passing through or above the piriformis can also predispose to piriformis syndrome, like we mentioned earlier. So this happens usually in 15% of cases. So when the sciatic nerve is injured, it usually results into foot drop. And foot drop is also known as drop foot. It's a condition that is characterized by the inability of an individual to raise the front part of the foot, which we know as the dorsal part of the foot. So that means that the individual has challenge with dorsiflexion, which causes the foot to then drag or drop while walking. So these individuals that have this usually develop abnormal gait, where the individual may have to lift their leg much higher than expected or higher than normal, higher than usual, in order to prevent the foot from dragging on the ground. So now that we've covered the neurovascular supply in detail, let's move on to apply the knowledge through a clinical question. The piriformis muscle exits the pelvis through which of the following? I mentioned in the lecture, take your time and you know where to drop the answer. Is it the lesser sciatic foramen, greater sciatic foramen, obturator canal, or the femoral triangle? Um, Next, which nerve is most at risk of injury during an intramuscular injection in the gluteal region? Which nerve is it? The superior gluteal, the inferior gluteal, the sciatic nerve, or the femoral nerve. As for this, let me just help you with this. So the sciatic nerve is the most at risk during an intramuscular injection in the gluteal region, especially if it's not well done. So to minimize the risk, the injection should be administered in the outer upper quadrant as mentioned. So this area avoids the path of the sciatic nerve, which typically passes through the lower medial quadrant beneath the piriformis muscle. So, but as for the gluteal nerves, especially the superior gluteal nerve, they could be at risk in the upper outer quadrant of the gluteal region through so that's the problem. So if the injection is administered at the upper outer quadrant, there is less risk. But if at all, if it goes too deep or so, it could lead into a complication. It could end up injuring the superior gluteal nerve. So though the risk is lower compared to sciatic nerve in the lower quadrant. So the upper outer quadrant is relatively safer because the superior gluteal nerve is more protected in that region and it's located deeper and closer to the pelvis. So the chance of directly injuring it is quite minimal if proper technique is followed. Okay, so the hip joint. We have addressed this during the osteology, and here is the femoral head, and you have the acetabulum. Then you have this fovea ligamentum. So the fovea for the ligamentum teres, or and the ligamentum teres is also known as the ligaments of the head of femur. And then you have this labrum around the acetabulum, so which makes the joint wider, increases the surface area, and increases the catchment of the head of the femur within the acetabulum. So the hip joint, we therefore understand it as a ball and socket synovial joint, and its a number of movements occur in it, including flexion, extension, abduction, adduction, and rotation. It has a number of ligaments responsible for the stability of this joint. And these ligaments, you will see them running from the three different bones that make up the hip bone to the femur. So you have the one running from the ilium, the iliac part of the pelvic bone, to the femur, referred to as the iliofemoral ligament, and that's actually the strongest. So for a ligament like this, understand the function of ligaments as almost opposite in direction to muscles. So a muscle located here is trying to bring these two parts together across where the muscle passes. But for a ligament, it's trying to prevent movement away from this area. It's trying to ensure that movement, that this area do not get separated whenever the area is extended, so to speak. So while you have, if this were a muscle, and bearing in mind that we are looking at the anterior um, part of the hip joint here, so if this muscle were to contract, then it will be resulting into some medial rotation. But this is not a muscle, it's a ligament, and the ligament prevents movement of both parts away in the opposite direction. So it prevents hyper movement of both parts connected in the opposite direction. So in this case, it's going to prevent hyper extension, okay, of the muscle, of the joint. It's going to prevent hyperextension of the muscle. So normally, muscles that offer extensional movements like the gluteus maximus, when they contract and they take um, the, the thigh posteriorly, ligaments placed on the anterior surface would ensure that hyperextension does not occur. And the strongest of those ligaments of the hip joint is the iliofemoral ligament. Next, you have another ligament that is running from the pubic bone, from the pubic part of the pelvic bone down to the femur, and that is the pubofemoral ligament. So this limits excessive abduction, all right? As muscles confer abductional muscle contract to confer abductional movement, ligaments like this would hold both joints together, ensuring there is no excessive abduction. Otherwise, the joints will become displaced and destabilized. Next, you have the ligament on the posterior side. So on the anterior surface of the joint, you appreciate these two ligaments, while on the posterior surface, you appreciate more the ischiofemoral ligament, which runs from the ischial part of the pubic bone, or ischial part of the pubic bone down to the femur. So that's the ischiofemoral. So this is going to resist movement in the anterior direction, which is in this case is internal rotation. So it resists internal rotation, prevents excessive internal rotation. So we also have ligamentum teres, which you saw in the very first slide, and that's ligament that runs from the head of the femur into the acetabulum. So it works to stabilize the hip, and it usually has an artery within it to supply the femoral head in infants and young adults. So in adulthood, in proper adulthood, the ligamentum teres has limited functions, and there could be tears in any of these ligaments, and depending on the level of tear and the cause of such tear, it would result in a commensurate level of instability and dislocation in the hip joint. So avascular necrosis happens when the femoral head undergoes ischemia when there is lack of blood supply to the head of the femur due to damage in the retinacular artery. So these are common movements that you find in the hip joint as conferred by the muscles of the hip joint. So you have flexion of the hip joints in this way, where you have the thigh raised up. So this is flexion. So if you take this in the opposite direction, then you have extension happening. Okay, so extension takes this back to the normal position, and extension further takes it backward, like you have in this case. Okay. So this extension is what the gluteus maximus, for example, does amongst other muscles. While you have abduction, taking the thigh away from the midline, as shown here, and then adduction brings this abducted thigh back to the normal position and further takes it in the opposite direction, like we have in this case. Internal rotation, when you rotate the thigh inward, and external rotation when you rotate it outward, leading to this kind of movement. So here is a table that summarizes the muscles that contribute to this respective movement. So for flexion to happen, so you have a number of muscles that we are yet to cover, which we are going to be covering in our discussion about the thigh region. So you have the iliopsoas muscle, which is a union of two muscles, the iliacus muscle and the psoas major muscle. So that's the iliopsoas. And you also have contributing to flexion, the tensor fasciae lata, like I mentioned earlier. You also have the rectus femoris, which you mentioned. We also have the rectus femoris, which we are yet to mention, contributing to flexion. Then sartorius muscle and the pectineus muscle, all contributing towards flexion. Then extension, you have the gluteus maximus muscle. You have the four hamstring muscles at the posterior compartment of the thigh, contributing towards extension. Quadratus lumborum also contributes to extension. Next, you have abduction, and for abduction, by virtue of the point of insertion of the respective muscles, we discussed all of them except the sartorius muscle. So the gluteus medius does this. The gluteus minimus is also an abductor. The tensor fasciae lata is also an abductor. And then you have the sartorius muscle, which we are here to discuss. Also, in adduction, which will also go to the contralateral side, so you have the adductor longus, adductor brevis, adductor magnus, gracilis. Of the muscles that we discussed that contribute to internal rotation is the tensor fascia lata and the gluteus medius and the gluteus minimus. We discussed about this. And in external rotation, you have the piriformis muscle, the gluteus maximus muscle, and the gluteus medius muscle, contributing towards external rotation. There is also the GOGOQ. Guess what that is? That's referring to the gemelli muscles. That's the external gemellus, and I mean the superior gemellus muscle. Then the first O is referring to the obturator internus. The second G is referring to the inferior gemellus muscle, and the second O is referring to the obturator externus, while the last G is the Q is referring to the quadratus femoris. So PGOGOQ is an acronym for the hip external rotators. So depending, you could create something similar for the other movements in the hip joints, and I will be looking forward towards your ideas and your suggestions in this regard. So you write an acronym for whichever of the muscle of the hip joint movements, and then the list of muscles in order to remember them easily. So the list of muscles that contribute towards each movement. So you can pick just one of the movements and create a mnemonic or an acronym, an easy acronym for the list of muscles, and you can pick all of the movements if you so wish, or more of them. so that we interact and see interesting ways to keep these mnemonics in mind. So here is P Google Q for the hip external rotator. So let's test your understanding so far. The ligament that prevents hyperextension of the hip joint is which of these four that have been listed? Iliofemoral, ilioischiofemoral, purofemoral, or ligamentum teres. So, to this extent, what is coxa vara? Is it an increased neck shaft angle of the femur, or a decrease, or a shallow acetabulum, or anteversion? So let me know what you believe the right answer is. Other clinical correlates that affect the hip joint. One of them is hip fractures, which could occur at different locations. So one of the most common fractures in the elderly is actually the femoral neck fracture. So especially in those with osteoporosis. And these fractures can disrupt the blood supply to the femoral head, leading to avascular necrosis, right? So we can also have what we call the intertrochanteric fracture, which is what you have here. So here is the neck of femur fracture, and here is an intertrochanteric fracture, which is most common in elderly patients as well, typically caused by falls. And this type of fracture can cause instability, and it's usually requiring surgical intervention. Okay, so we mentioned already the coxa vara, in which case the individual has an angle between the neck and shaft of the femur that is smaller than usual. That is the coxa vara. And when it is larger angulation than usual, that is coxa valga. We discussed this, and either of them, both of them leads to abnormal gait or hip pain, right? Then we also have a variation in the sense of femoral anteversion and retroversion. Here is what an anteverted individual, a person with anteverted femoral head, looks like, and this is what the retroverted one looks like. In the anteverted, you have the femoral head and neck, relative to the neck, relative to the shaft, being too anteriorly placed. So variations in the angle of can affect the range of motion at the hip and lead to instability or dislocation in some cases. So when there is anterior placement of the shaft relative to the head and neck of the femur, then this results into anteversion. When there is outward or seemingly posterior angulation or displacement of the shaft relative to the neck, the head and the neck, so that results in anteversion into anteversion. Yeah, so here is what you have in a normal individual. So here is the head and the neck relative to the shaft and the rest of the lower limb. So here is the angulation. So what happens in femoral anteversion is here is the head and the neck, okay, in its position, but then you have the foot and the rest of the femur. Okay, you have the femur being antiverted. It's inverted, so to speak. It is diverted towards the anterior, towards the midline too much, so to speak. So that is antiversion. Okay, femoral antiversion. That's an inversion of the shaft of the femur relative to the head and neck. Whereas in retroversion, you have it outwardly placed, which is more like towards the back. So that's why it's called retroversion. Retro refers to the back. So when you have the angulation being outward, that's the shaft of the femur relative to the rest of the head and relative to the head and the neck. So that results into retroversion. Okay. So dislocation is also possible, which could be anterior, it could be posterior dislocation. And as for the dislocation, posterior hip dislocation is usually caused by trauma, such as motor vehicle accidents, and it's associated with femoral head fracture. So this type of dislocation can cause sciatic nerve injury because the sciatic nerve is located posteriorly, and it can also lead to loss of hip movement. So when the dislocation is posterior, affected part of the head. And if it's an anterior dislocation, it's less common, but it can occur in the context of a high impact sport or trauma, right? And yeah, so some other anatomical variations that could happen include some individuals who could have, very loose hip joints. Such individuals are predisposed to dislocation or subluxation, especially in cases of hip dysplasia or connective tissue disorders like the Ehlers-Danlos syndrome. So in such individuals, you could have excessive movements at joints, and those excessive movements could occur at the fifth finger, known as the pink finger or the pinkies. So in this case, beyond 90 degree, an individual could extend. This is an extended fifth finger, pink finger. Okay, it could go as far as 90 degrees or even beyond that, which is not usually the case in normal individuals. So you could also have that affecting the thumb, right? And it could also affect the angulation of their knees. So it will also affect the angulation, how much they can bend and extend their spine entirely. So the elbows also, to test both sides, the arms are usually outstretched and the palms facing upwards. So in this case, you will see that the upper limb is not entirely straight. It's giving an angulation on the external, on the dorsal surface. So these are things you find, the hypermobility that you find in patients with Ehlers-Danlos syndrome. So these are amongst the anatomical variation. You also have osteoarthritis, hip osteoarthritis. So it's a common cause of chronic pain, particularly in older adults, and it can lead to reduced range of motion. It can lead to stiffness. It can cause difficulty in bearing weight or in activities that require bearing weight, such as walking or climbing stairs. So the clinical signs would involve the patient often exhibiting a limping gait or the Trendelenburg sign whenever the hip muscles compensate for the degenerative changes. So it will also lead to acetabular dysplasia, okay, where you have a shallow or a misshaped acetabulum, predisposing individuals to osteoarthritis, elderly joint degeneration. So we also have FAI, that's the femoral acetabular impingement, which comes in different types. So you could have the pincer type, or the cam type, or the combined type. So in the pincer type, it's characterized by excessive coverage of the femoral head by the acetabulum, such as the pins that you find happening here, I find showing here. So this leads often to a labral tear and a damage in the cartilage. So this is what is called the pincer type of the femoral acetabular impingement. So this is an impingement of, this is an impingement between the femur and the accetabulum, as the accetabulum as is hosting the femur, or as the femoral head is going into the accetabulum, so they are getting impinged against each other. So if it's the pincer type, it means a pincer is formed by the femoral, by the acetabulum, while in the cam type, it's characterized by a bony bump, on the femoral head that causes the impingement against the acetabulum. And here is the cam forming here, so leading to a pain and reduced immobility as well. So it can also be combined, where you have both the pins forming, and then you have the cam also forming. So it can eventually lead to hip arthritis if not addressed with surgical intervention. So this is, in the pincer type, you could also say this is an acceptable over coverage, okay, of femoral head deformity resulting from the CAM type. So all of these are variations of clinical conditions that could result from the hip joints. So you could also have labral tears, which we said is one of the complications of femoroacetabular impingement. So labral tears are often caused by trauma or hip dislocations, and they can lead to pain in the hip joint. So they can also lead to what is called a catching sensation, and also results into general instability of the labrum or general instability of the hip joint. So the anterior labrum is the one that is most commonly affected, but posterior labral tears can also occur, especially in cases of hip dislocation. So there could be variations in size and shape of the acetabular labrum or the acetabulum itself being predisposed or predisposing individuals to labral tears and hip instability. So another clinical relevance is the hip flexor strain, which is usually resulting from tendinitis. That's um, inflammation of the tendon, the joint tendon of the iliacus and psoas major. So the iliopsoas. So the iliopsoas tendinitis. So this results from so the iliopsoas tendinitis results from overuse or tightness of the iliopsoas. Okay, so when this happens, it results into hip flexor strains, often seen in athletes or dancers, and this can lead to anterior hip pain and impaired immobility. So the snapping hip syndrome, which we mentioned as well, where you have the iliopsoas tendon snapping over the pelvic rim or snapping over the femoral head whenever there is movement. Okay, so causing that snapping sensation. Yeah, you could also have a high riding iliopsoas tendon or an accessory muscle belly in the iliopsoas, contributing to the development of snapping hip syndrome. So here, to image these joints clinically, you have a number of imaging tools and facilities that we are already familiar with, including X-rays, especially for fractures, for bony illustrations, and then you have MRIs for soft tissues and to look at labral tears. So here you are looking at a detached labral tear with labral ossification in a 33-year-old male. So the person is an athlete, and this picture is an anterior-posterior radiograph that shows a large ossification in the superior periacetabular region that is arrowed here. And this is consistent with the radiographic finding of os acetabuli. So that is an accessorial bone that has ossified in this region. And here is a coronal T1 weighted MR arthrogram that shows intra-articular contrast material extending through the base of the superior labrum, as arrowed here, and this is consistent with a detached labral tear. So the periacetabular ossification on the radiograph corresponds to secondary ossification of the labrum that is shown during labral degeneration. So our concluding question, I think I have just two to go. So here, going a little more of a clinical scenario. So if you have a 40-year-old patient presenting with groin pain, pain in the groin and limited hip motion, and on MRI, it reveals a loss of blood supply to the femoral head. What is the most likely diagnosis? You have a number of ingredients in this question that has told you the answer already. But then feel free to think around this and drop your answer in the comment section. And this is the final MCQ. So let's see who has been paying attention. What is the primary action of the gluteus medius during locomotion? What's the primary action of the gluteus medius? Is it the flexion of the hip? Is it stabilization? Is it lateral rotation? Or is it stabilization of the knee? Stabilization of the knee. So remember, we've had 9 in total now, and I'm waiting for the first 5 students to drop their correct answers compiled, in the comment section. So let's see who get them all right. To summarize, we've explored the boundaries and layers of the gluteal region. We've also explored the superficial and deep group of muscles with their respective actions and functions. We also went through the hip joint, understanding what type of joint it is, the movements, and then the clinical correlates around it. We also appreciated the neurovascular structures, as the nerves and the arteries and veins in the gluteal region. We also explored key clinical correlates around both the gluteal and the hip region. So on this note, that's it for today's lecture. Thank you for watching and engaging. So I'll be looking forward to your comments with the correct answers to all the MCQs. Remember, the first 5 students with the correct answers will get a shout out in the next video, as the promise was kept in the current video. So don't delay. Get your answers in as soon as you can. Until next time, stay curious and keep learning. I wish you all the very best as we see you next time in class. Bye.